Yeah, I think in the spirit of the presentation today, we're going to be talking about how we've managed to accomplish to be ITV free with our SABRE program using our C-Series linear accelerator. And thank you for having me today. I dearly wish I was with you all. I love Chicago, so I wish I was there. My conflict of interest and disclaimer statement for you all to see. So where am I coming to you from today? I'm coming from Nova Scotia, and for those of you who don't know, Nova Scotia is a province, one of Canada's 10 provinces on the eastern seaboard, kind of highlighted there in red. We're known as Canada's ocean playground, and we're known for our oceans, our surfing, and our lighthouses. We have a population of just a little over 1 million patients that we serve here in Halifax with radiation therapy. And academically, we have a very collaborative department integrated with Dalhousie University with our medical physics, radiation oncology, and radiation therapists working together to treat just under 3,000 patients a year, including our stereotactic program, which is quite active. So for our stereotactic experience in Halifax, just to give you a little snapshot, we began treating stereotactic cranial fractionated and single back in 2003. So we've had quite a bit of experience with cranial stereotactic. We began SABRE in 2013, and we began with lung SABRE. We treat about 120 patients a year with just a little over 900 patients. It's slightly higher than that. These statistics came from August. And our liver program, we treat about 18 patients a year, and that's for all of Atlantic Canada. So all 4 provinces in Atlantic Canada, we provide stereotactic liver SABRE. We also treat other stereotactic sites, but these 2 are relevant to our ITV approach and our breath hold. We're quite proud to say that back in 2021, we were the first Canadian department to actually achieve Novalis certification, and we're quite proud of that. We accomplished that way back in March earlier this year. Specific to going ITV free and using a breath hold technique, we have a fair bit of experience. Just over 42% of our lung SABRE patients are treated in deep inspiration breath hold. And for our liver patients, we've treated all but 1 patient in breath hold, and that can either be deep inspiration or deep expiration. So a fair amount of experience at delivering this breath hold technique with our SABRE cases. So what did we have, what did we want, and how did we get there? So it's a matter of kind of describing to you how we were able to accomplish in our program, what we needed to do to get there, and what we've accomplished to date. So what we did know that we wanted is we wanted to expand beyond our cranial site, that's for sure. There was enough evidence certainly validating that stereotactic body radiation therapy was where we needed to go. We were very keen to take on lung and liver, especially because those patients were being sent out of province to get their treatment to either Ontario or Quebec, and we needed to provide that care closer to home. We wanted to make sure that for both lung and liver, we were providing that program with a very keen eye on motion management for lung and liver, and we needed to use as much as possible our existing technology. We are a publicly funded healthcare system, so we need to be fiscally responsible. So we needed to use what we had in-house as much as possible. So we dove into the literature and we reached out to our colleagues nationally and internationally, and we found that really in the literature, motion should be paid attention to and managed in some way when you get in that 5 to 10 millimeter range. So based on what we found from the literature and what we felt we could achieve locally and deliver SABRE safely, we chose a criteria of 5 millimeters. So our program has this magic number of 5 millimeters. Less than or equal to 5 millimeters, we would treat with the ITV method. So the patient would be treated with their motion unrestrained and what we consider free breathing, and we would utilize an ITV to account for that respiratory movement. We felt that anything less than 5 millimeters really was not using our resources to its best use. It wasn't warranted, but above 5 millimeters, we had enough caution to feel that we really wanted to employ this 5 millimeter technique, especially considering the high stakes of SABRE and stereotactic. So when our motion is small, which is less than or equal to 5 millimeters, we will of course use the ITV method. So the physician would contour on maximum inhale and maximum exhale, generate a ITV and a PTV afterwards. And knowing that we would have a slightly larger PTV as a result, we felt this was safe to use in patients with less than 5 millimeters. For those patients with greater than 5 millimeters, we wanted to use our existing technology. So we have a TrueBeam STX, which has all the bells and whistles of the flattening free, the high def multi-leaf, onboard imaging, and we have the RPM respiratory monitoring system that we already had in our department. So we used each of those tools to help accomplish our breath hold. What did we want? We wanted to make sure that we had a process that we were accurately measuring respiratory motion, and we needed, if we were going to choose a number so small and accurate as 5 millimeters, we wanted to make sure we were measuring that properly. We wanted a process for simulating, planning, and treating when it was less than 5 millimeters, and a parallel but slightly different process for greater than 5 millimeters. And of course, it had to be cost effective and easily fit into our department. So for our SABRE cases for lung and liver, the very first appointment that we have in the department with them is a 45-minute long appointment. This appointment used to be heavily involved physics, radiation oncologists, and radiation therapists, especially when our program was new. But with time and experience, this appointment is typically single-handedly managed by the radiation therapist, and it involves creating the patient's immobilization device and doing a fluoroscopy assessment of the patient's breathing. We have at our beck and call a conventional simulator, which we can use some days of the week, and we also utilize our TrueBeam linear accelerator quite frequently for its good imaging and its fluoroscopy capabilities. And from that fluoro, we determine very accurately whether that patient is breathing less or more than 5 millimeters. We also spent a fair amount of time with a pre-phone call and spending time during that appointment. And I don't think it can be stressed enough that not every patient is going to be able to do this breath hold maneuver, especially considering the large number of monitor units and the high dose associated with SABRE. And this would be the point where we would really make an assessment whether the patient was able to proceed with the breath hold or not. But if the patient's breathing motion was less than 5 millimeters, and we verify that under fluoroscopy, we would then proceed to a free breathing 4D CT for the patient. And the patient's IGRT strategy would be a free breathing cone beam CT, and we would actually treat that patient free breathing as well. If, however, the motion was greater than 5 millimeters, our first attempt is to do a deep inspiration breath hold with this patient. Now, if this was liver, we would attempt deep expiration first, but this model here is drawn out more for lung. If the patient is unsuccessful, and by unsuccessful, we mean that they're not able to hold their breath for at least 20 seconds and hold their breath for 20 seconds repeatedly. It's just not a matter of being able to do it once or twice. It's a very exhausting maneuver, and they must be able to consistently hold it with zero movement noticed on fluoro. And I'll show you an example of that. If the patient cannot accomplish either, we would then go to the free breathing and 4D CT ITV method. And of course, that would result in a larger target volume. If they are successful at breath hold and we're able to record that, then we proceed to a 3D CT for simulation, and we do a treat in the deep inspiration max inhale phase only. And we would do what we consider our stop and go cone beam for verification. I have an example here. I think it's going to run. Of a patient who has a upper lobe tumor, and you can see right now that the patient is free breathing. We have not asked them to do their breath hold maneuver yet, but you can see typical of upper lobe tumors, there's very little movement. We employ the graticule to measure either the visible lesion or any calcifications, and we verify that that movement is 5 or less millimeters. And this would be a good example of a patient that we certainly would treat with the free breathing route and not have to use any kind of breathing strategy. This next patient you'll see, typical of coming down lower in the lung, is got a fair amount of excursion. And this is a fluoroscopy acquired at our TrueBeam linear accelerator during that immobilization appointment. And the patient has upwards of about 2.5 to 3 centimeters of movement. So we would record how much movement the patient had with free breathing. And then we also verify under fluoroscopy how accurate and still the patient's breath hold is during their breath hold maneuver. And you'll see now the patient's holding their breath, and we would use the graticule and again, either the visible lesion or any calcifications to verify that not only can they hold it for 20 seconds, but they're actually able to hold things perfectly still with zero movement. Because if we're not going to utilize an ITV, we want to make sure that during that breath hold, there's no movement. So patient's holding their breath here, the heart is beating, but there's zero movement on this patient. So that would be an example of a successful fluoro and breath hold. We utilize the RPM system, and what we also know and are aware of some of the drawbacks or hesitations with that RPM system, which uses a fiducial signal. It's not always indicative of actual tumor motion, and it uses that external marker as a surrogate, and we're not really always sure if the external surrogate is actually representative of what's going on inside. So we're very diligent with our imaging, and we're worried sometimes about some residual motion within that patient's gating window. So we set a very strict gating window of 3 millimeters. So the patient has no greater than 3 millimeters of space in that threshold that they have. For image verification, we do what we consider our stop and go cone beam CT. It typically takes about 4 to 5 cone beam acquisitions where we only acquire the cone beam when the patient is in that 3 millimeter threshold, holding their breath. It produces a beautiful quality cone beam CT image. It's beautiful to match to. You can imagine there's no movement, there's no streaking. It's a lovely cone beam, but it is quite exhaustive for patients. So 4 to 5 breath holds per cone beam CT. For our treatment flow, once the patient is positioned and we're aligned to isocenter, we've gotten in the habit of acquiring a lateral KV to verify the deep inspiration breath hold is actually correct. And we found from experience that sometimes that external surrogate fiducial marker is not quite representative of a breath hold. So if the patient needs to take a bigger breath or a smaller breath based on that image, we do. We acquire the fluoroscopy before every treatment to verify that the patient is holding their breath for the correct amount of time with zero movement, and we do that before each fraction. We take that stop and go cone beam with a soft tissue match. We shift on anything greater than or equal to 1 millimeter. We apply those shifts, and once those shifts are applied, we would repeat that stop and go cone beam until we had ourselves under 1 millimeter. We would then deliver the patient using the beam hold function and only deliver the treatment while the patient is actually in that proper breath hold, allowing us to treat essentially ITV free. We also have a Novalis system set up, which allows us to watch the patient for movement during treatment. An example here of a patient who, on the treatment unit, we will allow them some free breathing maneuvers as we have the RPM trace at the bottom of the screen, following that RPM block going up and down, placed on their thoracic cavity. You can see the upper and lower threshold of that breath hold is quite tight at 3 millimeters. We would either do visual coaching with goggles or verbal coaching, whichever the patient responds to better. And then we would verify that the patient is actually able to hold their breath for the full 20 seconds within that 3 millimeter threshold with zero movement. As you can see, this patient here is quite successful. We fluoro for the entire 20 seconds because we want to make sure the patient isn't getting any kind of seeping or movement or escaping of air, which would cause some movement during that maneuver. And then we never exceed 20 seconds of either beam on or cone beam CT time on. So from all of this, we collected data. So with our 912 lung patients treated so far, we wanted to know what the difference was between our breath hold patients and our free breathing patients. So when we talk about couch time and how long the patient's actually on the treatment couch, we're not considering setup time or education time. We're talking about all of the setup verification, which includes the fluoro, the KV, and the multi-hold cone beam, and then the actual time it takes to deliver the actual arcs. The data that I have on the next page is for 4-fraction lung saber and 8-fraction lung saber. And all of those patients that we included in that analysis had 2 arcs with 6 MV flattening filter free. So what is our data? So at the end of the day, we ended up having for 4-fraction saber patients an average of 7.2 cone beam CTs over a 4-fraction saber. The range of daily cone beam CTs was anywhere from 1 to 7 cone beams until we were able to deliver treatment, whereas for free breathing, the range was 1 to 3 and an average of 5.92 cone beams. The data for our 8 saber, and then the very last column showing you the overall time. So for DIBH, overall, we had just a little over 42 minutes of imaging and treatment time, whereas for free breathing, it was just under 27 minutes. And you can see from the range, we had some breath hold patients that took upwards of almost 70 minutes to treat. And those were patients that were having a very difficult time, whereas the highest time we had was 39.5 minutes for free breathing. We do take into consideration, and just for your reference, some of the imaging intensive work that we do. However, we looked at some of the data as to how much dose we were actually delivering to accomplish all this, and we considered it to be not significant. So some of the take-home messages, if you want to do an ITV free method on a linear accelerator, it's certainly feasible and achievable. It allows you to mitigate that tumor motion beyond that, what we consider minimum standard of the ITV approach. We found it easily adopted into our department, and we didn't have to purchase many capital costs. It did decrease target size and OAR size, and we had beautiful crisp images to match with. However, a little bit of the buyer beware. Make sure you're appropriately selecting your patients and doing a lot of time and resources into educating your patient and choosing the correct patient for this technique. On average, it uses about 1.5 more cone beams compared to free breathing. They have longer acquisition times. You cannot typically image the patient for any non-coplanar arcs due to the limitations of a cone beam CT. And intrafractional imaging, so that would be imaging between arcs, is possible, but it's again going to extend your overall treatment time. So for our single lung saber that we do, where we require imaging between arcs, we do not do breath hold because it's simply too much breath holding for the patient. Your on-couch treatment time is about 1.6 longer. It takes us about 35 to 40 minutes to treat a regular lung saber patient, and it takes between 50 and 60 minutes from in the room to out of the room for breath hold sabers. And I just suggest that you be very diligent with your imaging to keep your thresholds tight and to make sure that you are a little wary of your external fiducials and that you use imaging to ensure that you are where you need to be.
Thank you very much, Caroline.
Thank you.
So I remind you, we will hold off questions till the end. For the people who are remote, please feel free to use the Q&A box to type in your questions. But we will hold off with answering session until all speakers have spoken.